I'm Alvaro Delgado Paredes, General and Vascular Surgeon. Today we are going to talk about two subjects: why varicose veins develop, second, what are the latest treatments. 80 to 90% of patients with varicose veins have a family history, or rather, there is a component of inheritance and factors that will have a chain reaction, like jobs or professions that imply long hours spent standing, pregnancy, constipation, overweight, or a sedentary lifestyle. These are factors that can have a chain reaction or lead to varicose veins when you have the genetic trait of suffering this illness. The veins that get damaged and at the same time are the cause of varicose veins are four. First cause, the great saphenous, also called long saphenous or saphana magna. 9 out of 10 people with varicose veins have this V damaged. Second cause, the other saphenous, small saphenous or lesser saphenous vein. The third cause are these bridges called perforating veins, which are so important that they even have a proper name in ancient literature. And a fourth cause are the pudendals, which are veins that come from the ovaries through the vagina and make up the pelvic varicose veins or gonadals. What is it that gets damaged? It's a gift from dad or mom that damages the venous valves, which are valves that open to allow the blood to flow upward and immediately close so that the blood doesn't flow back down, since it will tend to do so because of gravity. Wherever these valves are found in these veins throughout the inferior members. Therefore, the treatment is aimed at the four causes, since a great majority are directed toward the great saphenous, then toward the lesser saphenous, and then toward the perforating veins. Or it could be simultaneous. The patient could suffer from all causes or illnesses. This is what makes this a chronic disease with many causes that make it difficult for absolute control. Accordingly, the treatment is directed toward the causes, and the objective is to remove the damaged vein. We can control all the vascular surface system, which is this dark area here. The perforating veins we mentioned earlier as cause, including the pudendal vein, all of them can be managed or removed. Consequently, the treatment is aimed at removing the affected vein or veins. Not so with the deep vascular system. The deep vascular system is never seen, never touched. That one can't be treated with surgery. So, what procedures are there to get rid of these veins? Conventional surgery has always existed. The conventional surgery was to surgically remove the great saphenous or this V. We cut here, and we tear out the vein. That's why it's called the stripping or tearing of the great saphenous or lesser saphenous vein. This is what conventional surgery is. It's a bloody procedure that has been utilized for a very long time. It involves general anesthesia or regional from the waist down, and it involves an incapacity. As you can see, it involves many blood vessels and many incisions or surgical cuts. With the beginning of the millennium, more or less in 2000, new minimally invasive techniques appeared or were already being used in abdominal thorax surgeries like laparoscopic, thoracoscopic, and arthroscopic surgeries. In vascular or vascular surgeries, minimally invasive procedures also appeared or started being implemented to these surgeries. In this process, the laser or an endovascular laser with an optical fiber inside the blood vessel plays a very important role. As we mentioned earlier, the treatment for varicose veins is to get rid of the damaged vein. In this case, we will point out that it is this vein, the great saphenous, which gets damaged in 90% of patients with varicose veins. Therefore, we remove the vein using local anesthesia, and more or less at this level of the limb, we make a small incision, no bigger than 2 millimeters long, sufficient enough to fit a small hose, a catheter like this one. This catheter is introduced through this vein to about 3 centimeters below the junction of the great saphenous with the femoral vein. Through that catheter, we introduce an optical fiber and make it reach this point here. In other words, the joining of the saphenous femoral veins. We retrieve our hose or catheter, leaving our optical fiber in its place, and with a device, we spread a cold liquid around the vein, which contains anesthetic, adrenaline, and sodium bicarbonate. Once we completely infiltrate around the vein, we connect the optical fiber to a laser and trigger the laser inside the vein, which vaporizes and disappears. This is done with local tumescent anesthesia, which means that once the patient finishes his treatment, we put compression stockings that run from the foot to the upper thigh, and he leaves the surgery walking normally. In fact, we insist that the patient should not limp, that he should try to do all the dorsiflexion movements in the foot joints. The patient can go to work, walk, or go on trips. What he should least do is stay still.